Good afternoon. I would like to thank the organizing committees to give me a chance to talk today on the topic of minimized monitoring in stimulation cycle. Let's start on why should we minimize monitoring in stimulation cycle. We know that frequent visits to the clinic is time consuming and intense monitoring is also costly. It will create less psychological burden of treatment if we can minimize the number of monitorings in the stimulation cycle. This can also make ART more accessible to patients with so much work and life commitments. Altogether, we expect that this will lead to fewer dropouts from the ART programs, in which we know that cumulative pregnancy is very important. So in order for us to aim for the patients to get the highest chance of successful treatment, we need to keep them in the treatment as long as possible. In general, what do we monitor during the ovarian stimulations? We do the ultrasound monitoring to see the follicle development, the follicle growth. We do blood hormone profiles. We monitor on the patient's symptoms. Is there any benefits from blood hormone monitoring? Latest review from Cochrane database in 2021, in which the objective is to assess the effects of monitoring in the IVF and ICSI cycle with ultrasound only versus ultrasound with serum estradiol concentration in terms of live birth rate, pregnancy rate, and the incidence of ovarian hyperstimulation syndrome. It shows that there is no difference in terms of clinical pregnancy rates, cycle cancellation rates, and the incident of ovarian hyperstimulations compared those who undergo ultrasound monitorings only versus those who had ultrasound monitorings plus serum estradiol monitorings. In terms of the number of oocytes being retrieved, there were 0.32 more oocytes being retrieved in the group of the ultrasound monitorings with serum estradiol compared to ultrasound only. But anyway, the difference is not statistically significant. In terms of live birth rates, in all the studies being included, none of them report live birth rates as an outcome. So there's no information on the live birth rate outcome compared between two treatments group. So based on that review, it seems that the blood hormone monitoring may not give any extra benefits compared to ultrasound monitoring alone. Now, let's see if we can do ultrasound monitoring as alone. Is there a way to make ultrasound monitoring easier, more accessible to the patients? There's an article on editorial in RBM Online in 2020 talking about the home monitoring of ovarian stimulations and important step towards more patient-centered IVF. The concept of home monitoring. They had a concept that with home monitoring, it will give a milder and less complicated, less complex stimulation protocol in which reducing side effects and the need for intense ovarian response monitoring, and also reduce the number of frequent hospital visits. Because they know that complicated treatments is a cause of high dropout from the ART programs. For the self-operated home-based ultrasound monitorings, patients will be dispensed of ultrasound machines in which they're going to have the vaginal probe being connected to the tablet, okay, via the USB port, okay. then patients will be instructed on how to perform the ultrasound in order to obtain the pictures that we want. They do the scan first on the uterus before move on to the right and the left ovaries, and everything will be recorded as a video clip, and the data will be sent over to the cloud system in which it is well encrypted, and the data that can be retrieved by the doctor or the team, the ART team at the clinic somewhere else. And once the team, either the doctor or the nurses, has reviewed the ultrasound findings, they're gonna call back to the patients to instruct on how to continue the treatment or how to adjust the medications based on the findings. For the home-based ultrasound system, patient training is very important, but is needed only for the first-time users. Patients who are ideal for home-based ultrasound system, they're supposed to have normal locations of the uterus and ovaries, not without the pelvic pathologies. Patients with at least one complete ART cycles, they know pretty well how the growing follicle looks like, and they're the most suitable candidate for the home sonography. In remote area, if patients cannot perform the ultrasound by themselves, they can either go to local general practitioners, nurses, midwives, or gynecologists who can perform the sonography for them, and then the data will be sent over to the center for fertility centers. So the fertility specialists can assess the response and feedback on how to adjust the medication dosage. There are a few published studies on the exploration of the clinical applicabilities of the patient's operated home sonography in ART. All of the paper was done by Gouris. The first paper in the year 2009, they just do the survey to see how patients are willing to use the system. Patients are more than happy to use home sonography, given that the result of the treatment remains unaffected. In the following year, in 2010, they have a proof of concept of in the hospital setting, in which they ask patients to perform the system, the machines, the ultrasound by themselves under the supervision from professionals. They find that patients are able to perform vaginal sonography themselves. And in the year 2014, they report on the RCT on the patients operated home sonographies compared to traditional sonography by professionals. The reports, the outcome and costs are favorable in home sonographies. We're gonna go more into this paper after, on the next slide on the detail. And after they finish one RCT, they do another observational studies on the ICSI cycles using home sonography of the 100 cycles. They find there's only one case that patients cannot achieve the proper ultrasound pictures. This paper by Gouris published in the year 2014 on the self-operated endovaginal telemonitoring versus traditional monitoring on the ovarian stimulation and RCT. In this study, they randomized patients into two groups. The first one with the self-operated ultrasound is OET, and the second group, they do the traditional ultrasound monitorings, in which number in self-operated group is 59 versus 62 in traditional ultrasonography. They find that the number of follicles more than 15 millimeters at the time of egg pickup, the number of oocytes at the time of egg pickup, the proportion of the M2, number of embryo available for transfer, the number of top quality embryos at the time of transfer, and also the number of embryos for cryopreservation. There is no difference between both groups. Either they do the self-monitorings or traditional ultrasound monitorings. There's no difference. There are two technical failures in self-operating groups requiring patients to come in for the traditional scan. And for those who had self-operating sonography, 58 out of 61 patients eventually get to the point they can go to the egg pickup, and 54 out of 61 patients go all the way to the embryo transfer. The other 4 patients didn't have the transfer with either no good, there is no good quality embryo for the transfer, which is comparable to the traditional scan group in which 59 out of 62 patients go all the way to the egg pickup and 57 out of 62 patients go all the way to the embryo transfer. With the pregnancy result in the group of cell operations, the positive pregnancy test is 44% compared to 52% in traditional scan, in which there is no statistically significant. The ongoing pregnancy rate also 25% for self-operation compared to 26% for traditional scan, also no difference. On the patient's reported outcome to compare the self-operation to non-self traditional scan, there is a higher contentedness of patients and partner in the self-operating group. There's higher feeling of empowerment, discretions, and more active partner participations in the self-operating group. And also there's a trend toward less stress in the self-operating group. In terms of the cost of treatment, the overall cost is lower for the self-operating group, that is 455 euros compared to 894 euros for the traditional scan, in which the for the cost for the ultrasound to the patients and the transportation productivity loss are lower in the self-operating group, except for the material, the disposable material being used with the equipment of the scan that has to be paid more in the group of self-operating compared to traditionals, and the cost of the labor cost for medical staff to instruct the patients on how to utilize the system is more for the self-operating group. An average of 3 sonography was performed in traditional scan by care providers versus 5.4 ultrasound scan for a self-operating scan, in which the difference is statistically significant. So with this data, it shows that self-operating ultrasound scan could be considered, with more data in the futures, could be considered a way for the patients to do easy monitorings for themselves. Now, when we talk about the monitorings, we should understand why do we have to monitor during the ovarian stimulations. It could be for the gonadotropin dosage adjustment, or to when to start the GnRH antagonist. If you're going to go with the fixed protocol, you may not need to do the dosage adjustment, but for the flexible protocol, you need to know when the follicle size reach 13 or 14 millimeters before you start the antagonist. And to minimize, to avoid ovarian hyperstimulation, probably this back to the first one in that we need to do the proper gonadotropin dosage adjustment. So one main reason, so based on this slide, you're going to see that one main reason why we need to do the to do the monitoring is to do the proper gonadotropin dosage adjustment. So if we can go with the medicine that need no adjustment, then probably the monitoring could be minimized. With the development of the recombinant gonadotropin, cholecystropin alpha, in which it is the in which they use the C-terminal peptide from the SCG to add on to the beta subunit of the human FSH in order to prolong the half-life of cholecystropin beta from 30 hours go up to the 69 hours of cholecystropin alpha. With this change in the molecules, cholecystropin alpha, after being injected, it stays in the circulation for above the therapeutic range thresholds for over a week, okay, compared to traditional recombinant FSH, in which half-life is only 40 hours, in which they will be needed to do the injection on the daily. So with the use of cholecystropin alpha, we can avoid monitoring in terms of in terms of the dosage of the gonadotropin adjustment. So after you start the injection for the first time, you need to monitor only a week after to see if patients will need more gonadotropin and for how long. With the protocol of the cholecystropin alpha, initially they have advised that we get the GnRH antagonist being started on day 5 of the stimulation. That is considered the Frick's GnRH antagonist protocol. But nowadays, there is more and more data that shows that flexible protocol could be an option. So it means that GnRH antagonists may be started, in which patients may need to come in on day 4 or day 5 to do the scan to see if they need to get the GnRH antagonist or not. So in order to avoid the need to monitor about when we're going to get started with the GnRH antagonist, currently there is a trend towards the use of progestin to inhibit spontaneous ovulation during the ovarian stimulations. With the use of the progestin, we know that progesterone can block the LH surge. LH surge is caused by rising estradiol at the end of the follicular phase by positive feedback at the level of hypothalamus and pituitaries. And we know that progesterone prevents the LH surge despite the increase in the estradiol. This is the known effects of the oral contraceptive pills. Progesterone prevents LH surge at hypothalamus via progesterone receptors. And in monkey studies, they shows that administration of levonorgestrel at the beginning of the cycle, it can prevent the occurrence of the LH surge despite the increase in the estradiol, in which this suppression is reversible after levonorgestrel is discontinued. And with many studies about the luteal phase stimulation, it has consistently demonstrated that the LH suppressions has been consistently suppressed without the use of GnRH agonists or antagonists under the presence of the progesterone. With all these informations, it has support the use of progesterone to block the LH surge. The good things with this protocol is that progesterone is started from day 2 or day 3 of the cycle, or the next day after we start the stimulation medication. So progesterone is started at that point and then continue until the day of the trigger medications. So when we combine the cholecystropin alpha with progesterone, It is interesting that this protocol that has been introduced by Dr. Huang, a group in Taiwan, that they use the choline alpha with the methoxyprogesterone acetate for 45 normal and high responders. They start choline alpha on day 2 of the menstrual cycles and starting oral methoxyprogesterone acetate on day 3 and continue all the way until the day of HCG trigger. This shows that the number of visits between the choline alpha injection and the trigger is only 1.4 times plus and minus 0.5. So overall, it could be just only 2 visits, okay? Interestingly, out of that 45 cases, there's no case of premature LH surge, there's no incidence of ovarian hyperstimulations. So this could be an interesting protocol in which it is pretty easy and convenient to the patients with very low monitoring needed. So let me go to my last slide to conclude. I would like to conclude that blood hormone monitoring during the stimulation does not provide extra benefits compared to ultrasound monitoring alone. Ultrasound home monitoring concept is a possible future, awaiting for more data. Progestin tram stimulation with the use of choline alpha is a new ovarian stimulation concept of simplified protocol with few monitorings. Thank you.